Amy Howard is one of our graduating residents, and her grand rounds today is a really important topic that's had a lot of press lately, and we've had a much better understanding of how important a problem this is for high school, college, and even professional athletes. So I think we're going to get a good update. So, Amy.
Thank you. I think this is on. You guys can hear me? Okay. All right. I decided to choose this topic because my nephew recently had a concussion, and it was kind of interesting. He plays football and he's a swimmer, but it didn't actually happen with sports. He was waiting for the bus and at school, and a crowd full of kids, and they had the golf team at his school had gone on a field trip, and there was a loose golf ball on the ground, and of course the child decided to pick it up and throw it into the crowd of kids, and it ended up hitting my nephew on the head and knocking him out. And funny thing was the school didn't even tell my sister about it. They didn't call an ambulance, nothing. He passed out. They put him on the bus and sent him home. And so I just thought it was really interesting because he plays football at the school. And I can't believe they would do that and what they would do if he had done it in a football game. So, and it was something I didn't think that I had really seen much of in residency. I thought it was an important topic, but I think I've only ever seen one during residency. So I don't know how many you guys have seen, but I thought it was something we might be lacking in, so that's why I chose the topic. I have no disclosures or conflicts of interest. My objectives are to recall the recommendations outlined in the Zurich 2013 Consensus Statement on Concussions, to discuss concussion assessment tools used in pediatric patients, and to describe return to play guidelines and concussion management in pediatric patients. So the Consensus Statement on Concussion in Sports, this was the 4th International Conference on Concussion in Sports. It took place in November 2012 in Zurich, Switzerland. They had 3 previous meetings. They had been in different places, Vienna, Prague, and the 3rd one was also in Zurich. It's a conference that is organized by these associations, the FIFA Association, International Olympic Committee, International Ice Hockey Federation, and International Rugby Board. They pull in a bunch of concussion experts from around the world, and they try to come up with a consensus statement on the identification, treatment, and management of sports concussion to help increase awareness of concussions and their management. So the Zurich Consensus Statement gives a definition of concussion as a brain injury, and it's defined as a complex pathophysiologic process affecting the brain, and it's induced by biomechanical forces. And what you'll see in some of the literature is that concussions can also be referred to as mild traumatic brain injury. So I try to stick to concussion in this topic, but there are a couple of studies that I'm going to mention that refer to it as mild traumatic brain injury, so you may see that in the presentation, but they're interchangeable. The Zurich Consensus Statement also gives 4 features that are common of concussions. So a concussion may be caused either by a direct blow to the head, face, neck, or elsewhere on the body with an impulsive force transmitted to the head. Something interesting, Jessica just mentioned to me that her nephew had a concussion last year, and he had been hit in the jaw, and the force transmitted to his head and got a concussion, so don't forget about that. A concussion typically results in the rapid onset of short-lived impairment of neurological function that resolves spontaneously, but some of the signs and symptoms may evolve over a number of minutes to hours after the concussion occurs. It results in neuropathological changes, but the acute clinical symptoms largely reflect a functional disturbance rather than a structural injury, so you're not really going to see any abnormalities usually on CT or MRI. And a concussion results in a graded set of clinical symptoms that may or may not involve the loss of consciousness. Resolution of the clinical and cognitive symptoms typically follows a sequential course. However, it is important to note that in some cases they may be prolonged. So a little bit about the epidemiology of concussions. There are estimated about 630,000 ED visits annually for concussion among children ages 0 to 19. The CDC says that there's probably about 3.8 million concussions annually in the United States, but this was just for kids. And concussions can represent an estimated 9 to 15% of all high school athletic injuries. We see that girls have a higher rate of concussions than boys, and there's a couple of hypotheses about why that occurs. One of them is that girls have weaker neck muscles and a smaller head mass, and then that boy athletes may be more reluctant to report their injuries, being afraid to be pulled from play. So That might be why we see that.
Some people say boys have weaker brains.
And then a little bit about the pathophysiology. So it's an alteration in brain metabolism, they believe. This is based off animal models that they've looked at. So they think that it's a brain metabolism difference rather than structural injury or damage. It looks like it's a shear strain injury, and it leads to the following effects. So the sodium-potassium channels will open, and it leads to a massive influx of sodium and efflux of potassium, and this causes depolarization of the neurons. After that happens, a large amount of ATP is required to operate that pump, and so that increases the need for glucose, and that increases glycolysis, which increases lactic acid accumulation. Along with that, they also see a decrease in cerebral blood flow, which causes that decreased delivery of the ATP and the glucose to the brain, and then that causes some cognitive dysfunction and symptoms of concussion. It's just, I figured Charlie Brown probably has a concussion after Lucy did that too. Some causes of traumatic brain injury. So abuse can also occur. So you'll hear, you know, most of concussion talk is about sports causing concussions. That's where most of the research is done, but there's lots of other causes. So abuse is one of the causes, and about 1,400 cases of abuse of traumatic brain injury, including concussions, occur in the U.S. each year. Assault, motor vehicle accidents, pedestrian accidents, bicycle accidents, sports injuries. So about 300,000 sports-related concussions occur each year. The highest risk is with football overall, but with girls, the highest rate of concussion we see is with soccer and basketball. Other sports that can cause a lot of concussions include rugby, ice hockey, and lacrosse. And then falls. Falls are the typical cause for young children. Some signs and symptoms of headaches, or signs and symptoms of concussions, excuse me. Headache is the most frequently reported symptom. Loss of consciousness can occur, but it usually doesn't occur. It's usually just in about 10% of concussions. Amnesia and loss of consciousness may be important indicators for more serious injury. And then onset of symptoms or recognition of symptoms may not occur for several days or weeks. So the Zurich consensus statement gives 22 symptoms of concussions, and they divide it into 4 categories: physical, cognitive, emotional, and sleep. And so you see things like in physical, headache, vomiting. In cognitive, they can feel confused, difficulty remembering, difficulty concentrating. Emotional, they can feel depressed. And sleep, they can have increased sleep or decreased sleep. So there's just a lot of different symptoms, and they have a grading scale that they base these symptoms on, and we'll get into that later. So this is something that we need to get coaches to realize, that it's better just to sit them out if they're doubtful or concerned that they may or may not have a concussion. It's better just to sit them out and let them rest. The Zurich consensus statement says that we should be doing an on-field or sideline evaluation of the patients if we are concerned about concussion. So the first thing you want to do is address the ABCs, make sure their airway, breathing, and circulation are intact. You want to exclude cervical spine injury before you do your concussion evaluation. And you also want to determine a correct disposition of the player. So if it's in more of an emergent situation, they need to be sent to the emergency room. But if it's, you know, a concussion that seems minor, you might be able to refer them to a physician to be seen as an outpatient. And then you want to assess the concussive injury. So the Zurich statement, they advocate the use of this assessment tool for concussions, and it's called the Sport Concussion Assessment Tool, and it's the 3rd version of it. So SCAT-3, and they also have a child SCAT-3. So SCAT-3 is used for ages 13 and older, and then the child SCAT-3 is for children 5 to 12 years old. And they estimate that it takes about 15 to 20 minutes to complete. And just keep in mind that it hasn't been well validated in children, so you have to use your clinical judgment as well. You can't just use this, and I'll just try to show you real quick maybe what it looks like, and then on the next few slides we'll look at it a little bit more in depth. But it's a nice page, a couple of pages that you can print out, and it's got different assessment tools within it, and we'll go through each of these, and at the end they have some instructions for each of the assessment tools that are within it. So the The parts that it includes, it lists indications for emergency management, so it asks you a few questions. Was there a loss of consciousness greater than a minute? Those sorts of things, and that'll help you determine whether they need to go to the emergency room or not. Then it asks you a few questions to help identify potential concussion. Do they feel dizzy and confused? Do they have a loss of consciousness? And that'll help you determine whether you need to continue asking questions or not. Then it includes the Glasgow Coma Scale. It also includes Maddock's questions, which we'll go through in the next couple of slides, a symptom evaluation, cognitive assessment, neck examination, you're just checking for a range of motion, balance and coordination exam, and I'll show you the balance examination that they give, and the coordination examination is just finger to nose touching. So Maddock's questions, this is, it tests for orientation. So you're going to ask them, like, what venue are we at, what half is the game in, what team did you guys play last week, those sorts of questions, and you get a score off of that. Then you do the cognitive assessment, and this includes several different parts. So one part is, again, orientation. And then they have an immediate memory. This is where you give them 5 words and see if they can repeat the words back to you immediately. Then you do a concentration part, which is where you give them a series of digits, and it's increasing in number, the digits that you give them. And they have to repeat them backwards to you. And then they need to do another set of concentration exercises where they're going to name the 12 months in reverse order to you. And then later on in the assessment, you're going to do a recall memory where they have to give you the 5 words that you gave them again. See if they can still remember them. This is the balance of error scoring system, and it's called BESS. And it detects changes in balance following injury. And basically you have the patient do 3 maneuvers on both soft and firm surfaces. They kind of have them on a gym mat for the soft surface. And they're supposed to put their hands on their hips, and they're supposed to do it for 20 seconds. So the 3 maneuvers are that they do a parallel stance, a one-leg stance, and then this one's called a tandem stance. And you record whether an error occurs, and an error is defined as if they open their eyes while they're doing it, they're supposed to have their eyes closed, if they lift their hands off their hips while they do it, if they stumble, or if they put their leg into greater than 30 degrees of hip flexion or abduction, if they lift their heel or forefoot when they're not supposed to, or if they remain out of the position for 5 seconds. And then they talk about whether to scan the patient or not. So like I said, typically concussions do not show abnormalities on the CT scan, but what they see, this one is from the California American College of Emergency Physicians. They estimate that between 20 and 60% of children presenting to emergency rooms with head injury undergo CT scan. But when they look at children who have a GCS of 14 to 15, really only 1% of those children will actually have an injury that requires any kind of intervention. So we're really overscanning the kids. Zurich states that we should perform a CT scan if we have any of these suspicions on the patient. So a suspicion of an intracranial or structural lesion, if they have a prolonged disturbance of consciousness, if they have focal neurologic deficits, or if they have worsening symptoms. And other things you can consider scanning a patient for is if they have repeated vomiting, worsening headache, altered mental status, signs of a skull fracture, or a severe mechanism of injury like an injection obviously would need a scan if they were ejected from a vehicle. There are many apps available now on phones for concussions. They help to educate parents and educate athletes about concussions, but there are also some sideline evaluation apps that you can use if you're a coach to help evaluate patients at a game if they should have concerns for a concussion. This is an algorithm that was created by the Pediatric Emergency Care Applied Research Network. This was actually, it's in the next couple of slides, but it's an algorithm that they created to assess patients and to find out whether they needed a CT scan following head trauma. So you could use this with concussions as well to determine whether your patient needs a CT scan. So there's 2 different algorithms. There's one for children under 2 years of age, and then there's one for children over 2. So first you look to see if they have a GCS of less than 15, if they have a palpable skull fracture, and if they have altered mental status. If they present with any of these, then you're supposed to do a CT scan because of the high risk. If they don't have any of these, then you look to see if they have a scalp hematoma, a loss of consciousness greater than 5 seconds, or if the parent is saying that the child is not acting normally, or you can look and see if they have a severe mechanism of injury. So if they fell from more than 3 feet, if they had a motor vehicle accident with ejection, rollover, or fatality in the accident, if it's a bike or pedestrian versus vehicle without a helmet, or if they had been struck by a high impact object. If any of these are true, then you have the option of deciding. You can either do observation or you can do the CT scan. And they list some clinical factors here that may help you decide if they need the CT scan. So if they have multiple factors involved versus isolated factors, if they have worsening findings during observation, such as altered mental status, headache, or vomiting, you can do it based off of your own experience. So if you're not, if you don't feel comfortable, then go ahead and scan the kid. But if you feel comfortable, then you can opt not to scan the child. And then parental preference, I think that's kind of interesting. If the parent is insistent upon it, then they tell you to go ahead and do it. And if the child is less than 3 months old. And then this is the one for 2 years and older, and it's similar. Here you're going to look for a GCS of 15, a basilar skull fracture, altered mental status. And if any of those are true, of course, you get the CT scan. If they're not, then you look for vomiting, loss of consciousness, severe headache, and again, the severe mechanism of injury. And then you can decide whether to observe or do the CT scan. For management, some medications can be used to help with the symptoms of concussion. You can give Tylenol and Motrin for headaches. You can use Zofran for nausea. They recommended in one study treating with melatonin for sleep disturbances. It's important to note, though, that these medications really should only be used in the early phase of the illness. If the patient is getting ready to return to play, these really need to be stopped if they're participating in sports to unmask any symptoms of a concussion that they may be hiding. If the patient is of driving age, they really shouldn't drive if they have problems with attention, processing speed, or reaction time. We need to encourage good sleep habits in these patients, and they should avoid video games, loud music, and prolonged screen time, including cell phones, iPads, TV. The school may have to make accommodations for these patients when they return to school. So they may need a shortened school day, breaks during their classes, more time to complete their schoolwork, decreased workload, and they should avoid any tests as far as, standardized tests, especially SATs. They shouldn't be taking anything like that at the time. If they have prolonged symptoms, they may require a Section 504 plan, which is designed for students with a disability that affects their performance, or they could also have an IEP. If they work, they need to have work accommodations as well, which are similar to the school accommodations, a shortened work day, they should have breaks, they shouldn't be doing any driving or heavy lifting, no machine work, and they shouldn't be working at heights. And then you can also consider a referral to specialists. In the Zurich statement, they recommend a referral to a specialist if the symptoms are not decreasing by 3 to 5 days, and other places say that if the symptoms persist after 10 days, they should also get a referral. And then if the severity of the symptoms is concerning, you can refer them early as well. So the Zurich consensus statement gives these steps to return to play for patients who sustain a concussion and are going back to playing sports. So first of all, they say that no patient should return to play on the day of injury. They should do physical and cognitive rest until the acute symptoms resolve, and then they're going to start a graded program of exertion. After that, they need to see their primary care doctor and get medical clearance to return to play, and then return to play is the last step. So this is the graduated return to play that is given in the Zurich consensus statement. So it consists of the 6 steps. So first of all, they're going to do no activity, and the objective of this stage is recovery from the symptoms of the concussion. After that, they're going to add light aerobic exercise, such as walking or swimming, stationary cycling, and the point of this is to increase their heart rate. After that, they're going to start some sport-specific exercise, which are usually some light drills that they're going to do, and that's to add some movement. After that, they're going to continue doing drills. This is going to be more complex drills, and they can start progressive resistance training as well. And this is to add exercise, coordination, and cognitive load. After that, they're going to do full contact practice, and of course, like I said, they have to get medical clearance from the doctor first before they do this. But this is to restore their confidence and assess functional skills by coaching staff. And then if they progress past that, then they can do a return to play. When they are doing this return to play graduated program, they can proceed to the next level if they're asymptomatic at the current level. And each step should take 24 hours. So if you're on step 2, you can't go to step 3 until you're asymptomatic at step 2 for 24 hours. And when you first start, once you're asymptomatic and you start the graduated program, if you're able to progress through each step quickly, it should take about a week. But some people are going to have a step down on the program. And basically, if that happens, what's going to happen if you're asymptomatic at stage 2 and you go on to stage 3 and you develop symptoms, you have to go back to step 2 and do step 2 for another 24-hour period before you can progress again. And eventually, they should be symptom-free at rest and with exertion, both physical and cognitive, before returning to play. And this is something that we have to get the athletes to realize, that it's better for them to miss one game than to miss the whole season. So outcomes of concussions. Children and adolescents tend to have a longer recovery than adult patients, but we're seeing that most of the symptoms in pediatric patients resolve within 7 to 10 days. But if any of these are true on presentation, if any of these are true on presentation, then we can see a prolonged recovery in these patients. If they have more severe symptoms, if they have numerous symptoms, if they have a loss of consciousness greater than 1 minute, or if they have prior concussions. These are a couple of studies that were done on pediatric patients. So Barlow et al. Was a study on post-concussion syndrome after mild traumatic brain injury or concussion in 670 children. And what they found was that children that were older than 6 years of age were more likely to remain symptomatic than younger children. But luckily they saw that only 2.3% of the children in the study with the concussions were symptomatic for longer than 1 year. And then this study, Ponsford et al., was a study examining cognitive and behavioral outcomes after concussion in children. And what they found was that family dysfunction, psychiatric illness, and maternal psychological adjustment affected the patients, and they were more likely to have persistent post-concussive symptoms if any of those were present. The Zurich's statement also addresses grading. So grading used to be done, it's no longer done. They used to grade concussions as grade 1, 2, or 3, and some systems used mild, moderate, or severe, and this was all based on loss of consciousness. And the reason that the Zurich statement said that we shouldn't do any grading was that they have found that evidence with a brief loss of consciousness in a patient with a concussion does not predict their clinical course or long-term cognitive impairment. So if you have a loss of consciousness and it's less than a minute, it doesn't mean you're going to have a more severe course than somebody who didn't have a loss of consciousness. And also they wanted to make sure that the absence of loss of consciousness was not used to justify a more rapid return to play in athletes. So some complications of concussion that can occur. Post-concussion syndrome is defined as persistent symptoms lasting greater than 3 months. That's the DSM-4 criteria. Other places state that it's really just symptoms lasting greater than a month, and it's the same kind of symptoms that occur with a concussion: headache, decreased concentration, visual disturbances, those sorts of things. There's also second impact syndrome. This is pretty controversial, but it's the vascular engorgement that can happen after a hit. And what they see is that the vascular engorgement leads to a massive increase in intracranial pressure, and then they can have brain herniation, and this can lead to severe brain damage and death. And they see this in patients who have had a concussion just, kind of recently. So this is the second hit. there's some research that says that they're uncertain if a prior concussion is actually necessary for this to occur. This one study was Thomas et al. They studied patients. They had, I believe it was 200 patients that they studied that had sports-related injury deaths over a 30-year period, and they found 17 of those 200 patients died of injuries that looked like they were consistent with second impact syndrome. So it's not very common. Other things that you can see are convulsive motor phenomenon. So this is going to be like tonic posturing or convulsive movements that occurs within seconds of a concussion. It looks dramatic, but it usually doesn't cause any problems. They usually don't need any treatment for it. You can have post-traumatic seizures, which can occur days to weeks after injury, and these usually do need anticonvulsant therapy. You can have depression following a concussion, and like I said, that negatively affects your outcome. And then the most severe thing really is chronic traumatic encephalopathy. So this is a progressive degenerative disease of brain found in those with repetitive brain trauma, including people who have concussions as well as just hits to the head that don't cause concussions. And what they see is that there's a buildup of tau protein in the brains of these people on autopsy. And it's associated with memory loss, confusion, impaired judgment, impulse control problems, aggression, depression, Parkinsonian symptoms, and eventually progressive dementia. And this is a common topic in the NFL. A lot of players have sued over CTE. So prevention of concussions, education is the key. We need to make sure that parents and children who are competing in sports athletes, that they know the signs of concussion because it's really underreported. And also educating coaches about the effects of concussion, because we want to make sure that the coaches don't prevent the players from reporting their symptoms for fear that they're going to be pulled from the game and pulled from the season. We need to encourage seat belts, car seats and booster seats, no drinking and driving, helmets and protective equipment. And actually what they see is that helmets don't really reduce the risk of concussions, but they are necessary to prevent further head injuries. Limiting physical contact and placing limits on ages of patients who can do physical contact. So with hockey in particular, limiting body checking in hockey, and also the AAP recommends that players under the age of 15 should not be able to do body checking in hockey. Good sportsmanship, we see that athletes who go by the rules have a decreased risk of injuries. And we should encourage parents to child-proof their house, things like using window guards, using anti-slip mats in the bathtub. Those sorts of things can help prevent those falls and such that we see in younger children that lead to concussions. Also, playgrounds should have shock-absorbing materials such as mulch or sand. And then we have to also think about retirement from competitive sports and things that can encourage kids to think about quitting sports, or if they've had a lot of concussions, or with more concussions that they have, if they're having more progressive symptoms, or if the symptoms are lasting longer when they do have a concussion. Those are concerning signs, and they should consider retirement from competitive sports. And this was something that came up in the news last month. This is Chris Borland. He was a rookie actually for the 49ers, and he's already announcing that he's retiring from football because of the concern for head injuries. And he stated that from what I've researched and what I've experienced, I don't think it's worth the risk. And he was apparently pretty good. I'm not really familiar with him, but I also wanted to talk about Louisiana laws on concussion acts. So this is the Louisiana Youth Concussion Act. It's also referred to as Act number 314. This act was passed in 2011, and the purpose of it was that they wanted to have concussion education requirements for professionals who regularly interact with youth athletes to help them recognize the signs and symptoms of a concussion. They also wanted to encourage the removal of youth athletes from competition upon sustaining a concussion. And they wanted to establish requirements for return to play after concussion. And basically what it does is it requires the dissemination of concussion information to inform the public of concussion risks. So these are the requirements. Number one, at the beginning of the athletic season, information must be provided to coaches, officials, volunteers, athletes, and their parents to inform them of the nature and risk of concussion and the risks associated with continuing to play after concussion or head injury. It requires all coaches and officials to complete an annual concussion recognition education course, and then the athlete and the parents must sign a concussion and head injury information sheet, which provides information on the requirements which must be satisfied in order for the athlete to return to play. It also requires that a coach remove an athlete from a game if the athlete reports symptoms of a concussion, if the coach thinks that the patient has a concussion, or if they're not sure, and also if the coach is informed by anyone else who has training in concussions, like an athletic manager or trainer. If they tell the coach that they think the patient has a concussion, then the coaches are required to remove them from the game. And if the athlete is removed from the game for suspicion of a concussion, the coach has to notify the parents, and the athlete cannot return to play until they see their primary care doctor or an emergency room doctor, and they have to have clearance to return to play. And then after they return to play, or get permission to return to play, an athletic manager can take over from there, and they can manage the athlete's return to play. This is the CDC's campaign to increase awareness of concussions. It's called Heads Up, and it's an interesting website. It's actually pretty helpful. It has information and training for healthcare providers, athletes, parents, and coaches. So this can be used to train the coaches. Like I said, each coach in Louisiana has to have annual training on concussions, and there's a program on here that they can use to do that. There's also a providers training program, so it's a video that you can watch, and it has free CME credits if anyone's interested in that. But there's also things like handouts that we can use to educate our patients and parents about concussions. And it has even abilities to customize the handouts. For instance, you can change the logos. You can change this Heads Up logo to say like Heads Up Shreveport or Heads Up Bird High School. It's pretty interesting, so you should check that out. And those are my resources. And that's my little guy. Yes.
Would you comment on the blood biomarkers for concussion, or did you look at some of that information?
I did see that, but I saw it kind of at the end. I think Dr. Bass wrote something about it for contemporary pediatrics. Yeah, I think just more research needs to be done on it. I forget what the biomarker was.
There are two biomarkers in development, and the short of it is there a blood test you can do to assess the severity of traumatic brain injury, and one of them is related to the tau protein that you mentioned. Tau, go back to neurology, is one of the major problems in Alzheimer's disease. It's a microtubule-associated protein that is heavily phosphorylated in Alzheimer's and causes bad trafficking in the neurons. But the folks at LSU in New Orleans have actually worked with the Saints football team, and the group in Pennsylvania has developed a different biomarker. The Saints and LSU New Orleans have looked at what they call T-tau, which is total tau protein in the blood, and it correlates with symptoms. It comes up very rapidly after concussion, within just a few hours, and as the patient gets better, that tau protein comes down back to undetectable levels in the blood. So it's a potentially very useful biomarker that could help inform recovery. It's more objective than the patient saying, "Oh no, I'm not having any headaches. I'm doing fine. I'm ready to play, coach." Kind of thing. So I think that's a real exciting area of development that gives us some more objective data, and it also means fewer CT scans and the like, because you don't have to rely on brain imaging, which is mostly normal anyway.
Yeah, it was something I saw, but I kind of caught it at the end of when I was preparing, and I didn't want to include it and not know too much about it. So.
It's like a brain troponin. It's like a mind.
You may have said something and I missed it, but it's their, I know for some things they're doing the test before they play.
Yes. I didn't, like, so Zurich didn't require that anybody have pre-play testing, but yeah, it's something that you can have done. So there are some patients who have symptoms that can present like a concussion at their baseline. For instance, ADHD patients may have, you know, the decreased concentration and those sorts of things. And if you assess them after they've had an injury, you may think that they've had a concussion based on that, but it may be their baseline. So there is some thought that patients should have a baseline test done before they play, so that if an injury occurs, you have a comparison. It's not required, but yeah, it's something that you can think about doing. There's also neurocognitive tests that you can have performed by a neuropsychological trained person. It can be paper or computer wise that you can have done to assess them pre and post concussion.
Makes you wonder if we should even allow boxing when the whole purpose of the sport is to give a concussion.
So, Amy, one of the other exciting areas in concussion research is looking at treatments, because you mentioned some of the pathophysiology, and one of the things that's being better understood as we get spinal taps after concussions in research protocols is the importance of excitatory and inhibitory amino acid transmitters, glutamate versus GABA, and now we are beginning to have drugs that we use to say, treat epilepsy and other things that affect that balance of glutamate to GABA, and traumatic brain injury in general, not just concussion, but even penetrating trauma. That's an area where there's a lot of research going on. So we may have some pharmacologic treatments before too long also.
Why is it that you don't want them to do cognitive activity? Is that the actual purpose of doing cognitive activity or watching TV? Is this going to cause problems? Or?
So my understanding, and of course my daughter plays competitive high school sports, and so I've looked at all the concussion sheets and things, but a lot of kids who have more severe concussions, because of these excitatory amino acids, they basically makes your brain hurt. I mean, they're just is exhausting on the brain to exercise those factors.
That's what I mean.
Yeah.
If it bothers you, don't do it no more?
Sort of, yes, but the assumption is that most of those things will provoke more bothersome things. So it's really.
I mean, is there evidence that it does?
So it's what the recommendation is, cognitive rest, and again, that can be abused by high school students and for their own benefit. To say, oh, that class really bothers me. It makes my head hurt. I better not go to that one anymore. But. Yeah, exactly. Or the leak test.
Yeah.
So Amy, after looking at what's available from AAP and from other groups, you think as a general pediatrician you can play a significant role in helping understand when a child or releasing a child back to play?
Yeah, I think so. I think you know, the evidence shows that physicians are pretty good at recognizing the signs and symptoms of concussion and when to scan and when not to scan. Even without these guidelines, Dr. Rice was telling me that the PCARN guidelines, physicians were found to be just as effective without using the algorithm. So I think physicians are doing a good job, and I think we can.
Okay, sounds good. Okay, any other questions? If not, Amy, thank you very much.
Thank you.